So next is Dr. Nimale Stone from CDC. We're very lucky to have her now for the third or fourth time.
I think it's my third in person and fifth or sixth. You might have heard me as a voice on the phone.
So we're very lucky to have her. She's got lots of experience treating patients as well as on the CDC public health side, so she's a great resource.
Thank you. Good morning. I really love coming up here to Vermont, so I have to thank Patsy and Carol and the folks at VPQ for facilitating and making this possible for me. I actually really appreciate having Dr. Fatigati go first with her practical experience, because I think that all of those issues are so universal when it comes to improving the management of urinary tract infections. And it's not just long-term care. How many of us feel that hospitals got this right every time they use antibiotics for UTI? No. No. And so those same issues, those same challenges really are true across healthcare, even in primary care. And I think the work that you all are doing, engaging in emergency department efforts and educating your providers and your communities will go a long way. Because, you know, Patsy, the data you showed from the HEDIS data shows that they're doing it better in kids, quite a bit better in kids. And that comes from a long-standing effort around improving antibiotic use in children. And so I think there is precedent that we can do this better, but it takes a lot of effort. It takes a lot of teaching. So it was funny. I think Patsy and I have spent a lot of time together over the years, and so I had the same sort of desire to reflect on my experience working with the folks here in Vermont. And again, I love Vermont. I think you all are phenomenal providers. You do great work, and I talk about you all the time. And so no pressure, but I expect more, because you're a big part of my slide sets when I go around the country, okay? And I talk about the concepts of bringing acute and long-term care together, and you all were the poster child for doing that in this state. And a lot of states have recognized the value of bringing people from across care transitions together to talk and work together, because it's amazing the number of light bulbs that start to go off when you understand your colleague's situation and you understand what their resources or what their provider backgrounds and knowledge might be. And so it's a lot of what we talked about in the first few sessions that I came up here and presented was around antibiotic resistance and transitions of care. And I think what's interesting is that when you have those conversations, you automatically end up talking about urinary tract infections and device use as well as antibiotic use. And it sort of culminated for me, at least the last opportunity I had to interact with providers from Vermont was the IHI Vermont Antibiotic Stewardship Expedition that was just last year. And it was a series of webinars. How many of you participated in some of that? Anyone in the room? Okay, so you've heard me talk about stewardship and how we can apply concepts of antibiotic use principles in both acute and long-term care environments. And so it made me worry a little bit, because you have seen me so much, that I would need to think about what's new I can teach this very, very well-informed audience that's already been working on a lot of the topics that we're supposed to talk about today. Many of you have already been doing efforts to improve how antibiotics are being used in your facilities, and especially related to urinary tract infection. And so what I'm going to show you is some data from the literature that I think we can learn from. And hopefully together we can examine some of their study findings and say, is this consistent with what our experiences are? How can we learn from these research projects and integrate those lessons into our current work, or those of you that might be planning to do something with antibiotic use in this setting. I'm not going to belabor, because you had a very nice presentation giving you the background on the problem, but urinary tract infection is frequently diagnosed across all older adults, not just those in long-term care settings, although I think we focus a lot on that population because we see it written about and there's a little more data that comes out of it compared to community-dwelling older adults. But when you look at cause of hospitalization in the older adult population, urinary tract infection is a major driver of that as well. And we are confounded by the diagnosis of this infection because of asymptomatic bacteriuria. And you saw the numbers of how prevalent bacterial growth within the bladder can be in this particular group of individuals. And why is that? Why is it that as we get older, we have this symbiotic relationship with bacteria that it just hangs out with us in our bladders? Does anybody? Well, so some of it might be nutrition and hydration, and are we moving things through? But a lot of it is the accumulation of structural and functional changes in the urinary tract that leads to retention of urine in the bladder. So when I void, I don't completely empty the bladder anymore. And I know you can think of examples of this, right? How many people with diabetic neuropathy have neurogenic bladders? How many people who've had strokes often have evidence of urine retention from neurogenic bladder or stroke injury to the bladder? And so, and how many older gentlemen with enlarged prostates might have incomplete emptying of the bladder because there's a physical obstruction there? So there's a lot of physiologic changes that happen as a result of aging plus all of the comorbid conditions that we tend to accumulate, unfortunately, as we get older. The use of indwelling urinary devices of any kind, and of course the Foley catheters, we all know, what's the proportion of people with long-term urinary catheters that have bacteriuria? 100%. Okay, so everybody knows that. Good. And that's the same number for people who have suprapubic catheters, right? Because you're going from the outside environment into the bladder. It's not even though it's across the skin, it's not sterile. And the same is true for people with stents, for example, in the ureters and things like that. So any device and a lot of manipulation, even stones, can cause chronic bacterial colonization because you've got a foreign body and it's affecting the normal structure and functionality of the urinary tract. So then we get stymied. We have these positive cultures everywhere. How do we know what's a real symptom and what's not a real symptom? And this is a real issue, and I think we focus on the misattribution of nonspecific changes, saying you're wrong, that person's lethargy is not because there are bacteria in their urine, because you know what? The bacteria was there last week, and it's going to be there next week. So the lethargy is probably something else. But that's where we tend to focus a lot of our time. But if you actually look at bacteremic UTIs, what I don't think any of us would argue is a true infection, you don't always see the typical dysuria, frequency, urgency. You may not even see rigering in the older adult population because their response to systemic infection is sometimes blunted. And that's also physiologic changes in the immune response with aging. So I don't blame us for being stymied by this. And you can see then how it's not surprising. We use a lot of antibiotic. It drives a lot of antibiotic resistance, especially to those frequently prescribed drugs for uropathogens. And I'm certain that some of you have watched resistance emerge in one person as you follow their history of antibiotic exposure after exposure. So the first time the E. coli is amoxicillin susceptible, the next time it's Bactrim susceptible, the next time it's Cipro susceptible, but by the fifth treatment course, guess what? You don't have any of those drugs available anymore. And that's a real phenomenon that sometimes is the tipping point, and I think the carbapenem resistance in Enterobacteriaceae, the CRE or CRE that we're talking about, that's finally getting us all to pay more attention to this problem, because we don't have what we consider the biggest, baddest, most awesome antibiotics available. Those are gone, and there's a growing proportion of organisms, unfortunately, that we're losing ability to treat. Older adults are at greater risk for having antibiotic resistance. Often their healthcare exposure is a driver of that. Their antibiotic exposure is a huge driver of that. They also are at high risk for the adverse events related to antibiotic use. Whether that antibiotic is appropriate or not, the fallout in adverse drug events and things like C. difficile infection, which tends to be more severe in that group, leads to more relapsing disease, and so it's never benign. And Dr. Fatigati talked about the lack of benefit. Well, there's no harm in giving this drug, right? They don't tend to, there's not a downside. They're well tolerated. It's just a pill. But actually, it isn't at all benign. And especially in the older adult population, antibiotics as a class are in the top 2 causes of adverse drug events in nursing home residents, which is data that, frankly, I find a little surprising, and I don't think we talk about it enough. You know what we talk about? What drug class do we talk about? Antipsychotics, and everybody knows it, and there's been huge, huge initiatives around antipsychotic use in this population. Well, why are we just talking about that drug class? When, if you look at the numbers of adverse events and preventable adverse events, it's just as high for antibiotics. And sometimes the non-preventable, what we call non-preventable, is higher because we think, well, they needed the antibiotic, and so we couldn't help it. It's just unfortunate that this happened. But more and more, we're starting to recognize, well, maybe we didn't need the antibiotic, and that would actually make this a preventable event if we thought about the appropriateness of our drug use. So it's not benign, and there's a lot of drug going out there, and so we are compelled to do something about it. And I really, again, appreciate all of your efforts in this area, and I know that you could teach me just as much as I'm going to try to discuss with you. I think this audience in particular has a lot of experience. So as you are thinking about putting out there a QI effort or a management algorithm or implementing a new form, here are some of the big picture questions that I think we have to consider in terms of our success in that endeavor. The first one being, how valid are the criteria that we are using to diagnose and define a symptomatic urinary tract infection? Is there a gold standard? Is there a test we can do that says, ding, 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 this is definitely a UTI, this is the one? No, right? We've just heard that half the people out there have positive urine cultures, so that's not helpful. Pyuria, not helpful. Signs and symptoms, nonspecific, not helpful. So that's a real issue. So if you don't have a gold standard, and you're trying to convince your staff or your medical providers or even your residents and family that there are these criteria that we should all be applying in order to diagnose and treat these infections, if they don't agree with you, how likely is it that they're going to implement those algorithms, utilize those papers, sustain that once you stop, looking over their shoulder and prompting them to do it? It's a real risk for us if they don't buy in and agree with us that these are valid, or if not valid, because validity is hard to prove, at least useful in some way. Okay, at least useful. I can get something out of using these criteria, that they make sense to me. Along those same lines, I think how we are using diagnostic testing for this particular condition is something we have to really reevaluate. For all of the reasons that you've already heard, that a positive dipstick test is not reliable at all. There's such a high proportion of abnormal protein and white cells and even nitrites that we can't rely on our tests alone to convince us or to reassure us that we're doing the right thing in terms of treatment. So the first question may not be, how are we using the antibiotics? The first question might be, how are we using the diagnostic tests? Because how many of you feel that your providers are being, browbeat by this positive culture? Well, there's a culture here. We have to do something with it, right? And so that may be our first step. Along those lines, whatever algorithms, flow sheets, management pathways that you're trying to promote, you have to take a minute to assess what is the perception of those among the frontline staff that are going to be using them every day. Because it gets at the same issue about criteria and the utility of those criteria. If they don't agree with the management algorithms, if they think you're wrong, you know what? Altered mental status is a UTI in this lady. I know it. I've seen it for the last 20 years. I've cared for her. I'm not going to change my practice. Well, that's a valid belief for them, and there has to be more engagement, or there has to be more buy-in, I think, in order for you to, say, shift that perception and shift that behavior and that practice change. And I think we all talk about data, and it's how do we use data to evaluate the impact of our activities, and we'll talk about some ideas. I apologize because I don't know that this is very clear for you to see, but these are the 3 big guidance papers that people talk about around defining infections and using antibiotics. Mostly these are targeting long-term care providers, but I would say again that a 75-year-old in a nursing home shouldn't present differently because now they're in a hospital. I've never quite understood that. And I think in fairness, you all could argue with me about why does NHSN have different diagnostic criteria for UTI. I mean, shouldn't it be age-based? And I wouldn't disagree with you. So the original paper, the seminal paper that brought the idea of surveillance, specific criteria for surveillance in long-term care came out in 1991. It's over 20 years old, going on 25. Alison McGeer is a Canadian researcher. She brought together a group of experts in the field, and it really was the first time anybody put down on paper something for long-term care surveillance programs. And that's why it's the industry standard, and it was the only thing out there for a long time. And then in 2001, Mark Loeb, another Canadian, see how they're leading us along, by the way. Your guys are close. Maybe that's why Vermont is so progressive, because you're so close to Canada that you interact with them and they pull you up too, and you're ahead of us in Georgia. Mark Loeb and this group, he actually wrote criteria not so different, really, from the surveillance definitions, but a little bit different, trying to help clinicians say, when I start an antimicrobial to treat a specific infection, what are the minimum criteria that should be there in order for me to justify that use? In addition, his paper really came out strongly about the importance, I guess, of urine culturing as part of the assessment process. In the McGeer original definitions, remember, laboratory diagnostic testing was not a part of those criteria at all. And at that time, that was appropriate because 20 years ago, I don't know that all the nursing homes had ready access to diagnostic testing. And some of you may still today struggle with getting access to diagnostic testing, but by and large, it's a lot better now. And I think the complexity of the care of residents that you take into nursing homes and skilled facilities, the complexity is so much higher now that you have to have ready access to diagnostic testing as part of providing safe health care. And that's my opinion, but I would stand behind it because I'm seeing so many more people who look like hospital patients going into nursing homes today. And you have to be able to manage them. So the CDC SHEA definitions that came out last fall, or 2012, they included positive urine culture as part of the definition. But otherwise, signs and symptoms-wise, very similar to the Loeb minimum criteria. There's very few differences. So I'm going to switch now to some of these papers and show you sort of aspects of this challenge as they suspected urinary tract infection triggered by the clinical staff, so the nursing home frontline, nurse assistants, LPNs, RNs, also talking with their medical providers. When they had a trigger and suspected UTI, they went back and did another assessment of mental status, functional status, and then looked to see if there was laboratory data that could support that clinical suspicion. So in the 12-month period, about 30% of the cohort had been identified as suspected of having a UTI. And the way that these authors defined laboratory support of a UTI, you can see here, definite if there's high colony counts plus white cells. Possible if there were high colony counts but lowish white cells or lower levels of growth in the urine culture. And then they had a cutoff of less than 10,000 for not a UTI, okay? Now, that was their approach. So the first thing I'm showing here, they followed people for at least 3 months or longer. The incidence of UTI in this group was 1.6 per 1,000 resident days. That's actually not that inconsistent with other data I've seen. The triggers, so what was it that staff first noticed that made them think, I think there's a UTI? The very top of the list, change in mental status. Second on the list, change in behavior. Those two alone accounted for almost 70% of the triggers in this 100 or so residents that were in this review. Down toward the bottom, dysuria, that's 6 out of their 100 plus people. Change, dehydration, 2. So it's very much those non-specific, she's not acting right, he's not acting himself, somebody fell. Those are the major triggers clinically that people are using. Of those suspected cases, 66 ended up having documentation of localizing urinary tract symptoms, fever, or both of those, which actually is not as bad as I thought it might be, 66%. Only 43% of those people suspected by staff of having UTI ended up having laboratory confirmation of it, which is why including laboratory testing as part of the definition is actually something that we felt was important to do. So what do we see? A little bit of a disconnect between what I think might be a UTI and what actually meets definitions and evidence criteria of a UTI. Antibiotics were given to over 60% of people, 95% of the people who had that positive lab evidence, but another almost 40% of people that had no laboratory evidence of a UTI got treated with antibiotics, okay? So that's a lot. When they retrospectively applied the McGeer definitions from 1991 and the Loeb minimum criteria that I just showed you, less than a quarter, a very, very small number of people ended up meeting either of those definitions of UTI, those criteria-based definitions. And this is what I'm saying about how valid are they, what do your providers believe about them? Because if they don't buy in, it's really going to be hard to change their practice. Interestingly, if they had used the Loeb algorithm to define who should get a urine culture, 75% of the people in this study would not have had lab testing done at all. And so it actually lines up pretty well then. If they hadn't tested and treated all of those people, then you would have had 100% agreement with the people who met the definitions and that, but as it was, we have a big group of people out there who are being treated, managed as suspected UTI when maybe the algorithm wouldn't have suggested they should. Yes?
So I'm getting a little lost in the numbers, but does that...
So the question was, if these numbers of people meeting the Loeb or McGeer definitions are so low, does that mean that we're missing true UTI? That is a very good question. It's impossible to almost answer because it gets at the crux of the problem. Are the criteria wrong, or is the practice wrong? And it's very hard to discern that. I'm going to show you some other studies. It may help sort this out, it may not. But I think that's the real fundamental issue with the validity of these criteria. So I'm going to move on to a different study. This was a cross-section of all of these residents residing in a large group of nursing homes, 32 in total. They underwent a point assessment, almost like, today, what's going on? We're going to assess you for clinical symptoms of urinary tract infection, as well as a portfolio of what they call diffuse, or the nonspecific geriatric symptoms, like not acting right, altered in some way, confused, lethargic. And then they also did a follow-up specimen collection for urine and did a urine analysis. They were excluded or not eligible to be part of this cross-sectional study if they had severe incontinence, and that was because collecting the urine specimen would be very invasive, and they couldn't justify doing that appropriately, I think. If you had an indwelling urinary catheter, or if you declined to be a part of the study. So of the 1,200 people in those nursing homes that could have participated, they had about 650 actually agree to do it. And you can see the large number of people that didn't participate were because they weren't candidates for being in the study. Only about 10% of the total actually declined to be involved. So it's not that bad. They excluded more than people didn't want to participate. What they tried to do was something kind of interesting to me. They tried to look at, because they were testing people who had signs and people who did not. So they were getting everybody. And then that allowed them to look at what's the predictive value of the positive lab culture in predicting or being associated with a particular symptom. So what is the likelihood or the predictive value of a positive urine culture ruling in confusion? Okay, that's what the etiologic predictive value is. Now, the numbers here, I was thinking I should send you, Carol, the references so you can share this or post it so that people can actually look at the paper, because it doesn't actually present very well. Overall, about 32% of their cross-section of people had bacteriuria, okay? And then when you looked at the prevalence of that bacteriuria across some of those nonspecific or diffuse signs and symptoms, 45% of the residents who had confusion also had bacteriuria. But that meant that 55% of them did not, right? 40% of them with fatigue had bacteriuria, 60% did not. Interestingly, 40% with dysuria had bacteriuria, 60% did not. So that's interesting to me. It tells us that even some of those signs and symptoms that we really put our hats down on may not be completely correlating with symptomatic UTI or bacteriuria. There are certainly other reasons for someone to have dysuria, and I think that's one of the interesting messages that comes out. What the conclusion from all of those calculations around the predictive value, none of these symptoms that they assessed showed predictive value that was high enough that the positive urine culture was likely to explain the presence of that symptom. And because of that, the authors concluded that the urine culture is of little to no help in clarifying why somebody has these diffuse symptoms. It doesn't help you discern why they're fatigued. It doesn't help you discern why they fell, why they're not acting like themselves, or why they're confused. That is a huge paradigm shift for most of our providers. It's a huge paradigm shift for our families, right? Because what if we taught people for the last 20 years, mom's altered, she must have a UTI. And what this study is showing is that that's not really true. And in fact, none of these typical diffuse changes in behavior and functionality can actually be explained with the positive urine culture. And I think that's huge. I think that's important data to get out there. Another study, this is sort of looking at what I call the tail wagging the dog phenomenon, which is I have a group of residents and I'm treating them for something with an antimicrobial. But the only clear driver that I can explain why is a positive culture. So this study looked at all of the antibiotic use for urinary tract infections across 4 different facilities in 6 months. 50%, almost 50% of the antimicrobials being prescribed were in residents with no documented signs or symptoms of localizing urinary tract infection, and no other signs and symptoms either. So these were truly asymptomatic people. It wasn't like, oh, something was changing, I didn't document it, but I was worried, so I started the drug. It was something changed. I sent a test. I got the test back. It's positive. They're fine, but I have this test. That's one of the concerns about the way this data shows. And I think that is, again, this question of, are we being led by our diagnostic testing? And if that's the case, do we need to evaluate how we're using those studies? So let's switch. So those now, we've talked about the validity of the criteria. We've talked about the challenges with interpreting the testing. Let's talk about a project that looked at implementing a management algorithm for UTI. This was actually done by Mark Loeb, who was the one who developed those minimum criteria. It was a really well done study, a cluster randomized trial, meaning you had a group of intervention facilities and a group of usual care homes. You didn't have staff crossing over. You didn't have sort of the risk of people getting corrupted, if you will, by the intervention and then going back and changing their practice in the controls. They had a series of management algorithms, and this is one example of it, and it basically is saying if there's a fever, go down this path of assessing for UTI symptoms or not, and then what do you do? And so they had a fever-based algorithm, and then they had a urine culture positivity-based algorithm as well to help reduce antibiotic use for the non-symptomatic or the people who weren't meeting those minimum criteria. When they implemented that, they did show a 30% decrease in the UTI-indicated antibiotics among their intervention homes. So you saw impact. Interestingly, of course, with a lot of our long-term studies or longitudinal studies, what we started to see was creep. So here they were together at baseline, then here's my intervention going down, and then, oop, you know what, I'm coming back to meet you. You get that loss of the sustaining effect because people start to go back to their old practices, or maybe your champion left the facility and now nobody knows about the study anymore. So things often over time tend to go back to baseline. But they saw this initial decrease. Also very important, they did not see any increase in hospitalizations or mortality among the residents in the intervention home where less antibiotic for UTI was being dispensed versus those in control homes. And I think when you talk about outcomes in these kinds of antibiotic stewardship efforts, making sure we're not inadvertently hurting people, right, that there's not an adverse consequence to holding those drugs is very important. Now here's the rub. The total antibiotic use did not change between the intervention homes and the control homes. So what does that mean? To me, it tells me that, okay, so my providers decided they couldn't use this drug for UTI, and they either found or, maybe they looked for and actually identified a legitimate infection that they would have misattributed, or they just found another reason to give the antibiotic. So it was a little disheartening because I think all of us would have expected the total antibiotic consumption to go down in the intervention homes if you saw a 30% reduction in their UTI treatment, right? So that's the only sort of, oh, darn kind of part of that study. But I'm not going to talk as much about that as I am going to talk about a follow-up study that this group did. The study group went back to the providers in the intervention homes to do some interviews, some focus groups, to understand their perception of the value of those algorithms. And this is getting at that third question I had posed to us at the beginning of this presentation. What is the perception of the individuals that have to use these tools in terms of the value, as well as what are the problems with them? What are the obstacles, if you will? And so in the next few slides, I'm showing you screenshots. I'm just going to read a couple of them. So this was staff perceptions of diagnosing. Well, in long-term care, you don't have access to a quick lab service, so you're often guessing what the problem is. There's one sign that we all around here use a lot, and that's elevated blood sugar for the diabetics. They may be one of the first signs that something is wrong. Now, I don't think any of us would disagree that it's a sign that something is wrong. But I think where we get into trouble is making the assumption that that sign is that the urinary tract is wrong. And because that's such an easily accessible, easily tested system, we go there. We do the test, we get the positive, and it kind of confirms our belief system so we don't question it. One last, they said, we have over the years identified a number of people very prone to UTIs, so when they start describing symptoms, we just go ahead and test. It could just be we just go ahead and treat, because the likelihood is a lot of those people, they'll test and they'll be abnormal tests. But that's the background perceptions and knowledge of the staff that participated. And I don't think that anything they're saying is unique to Canadian nursing homes. I think that this is very, very accurately describing what a lot of facilities believe. How about the value of the pathway? The top one, I think it made our staff more aware of the hydration needs of our residents. Instead of saying, oh, well, they have smelly urine, they must have an infection, they say, oh, they have smelly urine, we need to give them more to drink. I love that one, actually. That's a great one. They have seen a change in the way delirium and confusion are treated now. They're not only seen as, oh, it's a UTI. People are now looking for other reasons. Maybe it's pain. Maybe it's constipation. It's expanded the staff's horizons about what could be causing the problem. I think that's fantastic. Nobody would argue that somebody becoming agitated or changing their behavior abruptly is not a sign that something is happening. I think the question is, are we looking enough at what it is and being a little broader in our approach. The last one, when we started the study, we had a much greater number of urines being sent out. I'm not getting people asking to send urines now or notes telling me that someone has strong urine. They're automatically increasing fluid intake now. So actually, this had some educational benefits to it. Just implementing these management algorithms had an impact on how people were thinking about UTI management, and that is a positive thing. What were some of the challenges? So this is really interesting, actually. Getting the support of all the personnel was difficult. The medical director was not that keen. It was me, the DON, who said, come on, let's try this. The next one down. Part of the problem was getting physician buy-in. Even physicians that are familiar with the pathway, they still order urine even though the person isn't meeting criteria. They don't want to be told how to change their practice. So yes, we throw providers under the bus, but sometimes we deserve to be under the bus because we are a very hard group of people to change. We don't like to be told that we're doing something maybe not the best way. We need to be sort of tricked into thinking it was a good idea. And then I'm far more likely to help out. I mean, it's true. We're sort of joking, but I can tell you, if you confront anybody, not just physicians, but if you confront anybody and say, hey, you're doing this wrong, their first response is going to be, what do you know? You don't know. You don't know what I deal with, and you don't know my patients, and thank you very much. I don't need your help. So I often approach people with the sort of, I just don't know, maybe you can help me. I see this funny thing with this urine data. What do you think is happening? Do you think, well, look at this paper. I found this paper. Maybe you could help me interpret it. Maybe I'm not reading it right. You know, you have to get people to buy-in. They have to believe in it. I think that's the messaging here. A lot of the providers in these homes didn't necessarily believe in these algorithms completely. And so they weren't necessarily willing to follow the protocols because of that. So barriers. There are differences in our doctors. One doctor is quite adamant about not treating people if they're not symptomatic. But then the other guy, he's always treating a positive result. So then you've got families. That came up. You have families really involved in the family member's care, and they are demanders. I think my mom has an infection. I don't care if she does or doesn't. You have to put her on something no matter what. I think that's very real. I think that's also because we've been very good at teaching families that this is the paradigm. Your mom's not acting right. She has a UTI. She needs an antibiotic. Oh, she's better. Well, then, of course, as a good advocate for my loved one, I'm going to take that to heart, and every time I see that problem in the future, guess what I'm going to ask for? So we have to undo our education of families and residents if we want them to change and to buy into what we're doing. Now, what can you do to overcome some of those barriers? Well, one of the suggestions that they got was maybe there needs to be a different pathway because of the cognitively impaired residents who may not be able to show or describe their symptoms to you. There was a lot of concern about whether there needed to be a different approach for people with diabetes and dementia. Those were the themes that came out with this group of focus providers, and they wanted to have an out. In any study you do, you have to have an out for doctors or nurses if they have reasons to vary the protocol, because it's people's lives we're talking about. That has to be clear in a study or any kind of program. It doesn't always fit one case. There has to be a way to. So these are the attitudes. I don't think we're surprised by any of the comments or quotes from these individuals. I think it's very real, but these are the very real perceptions and attitudes that we have to be thinking about when we talk about changing their approach. So now, this is the last study I think I'm going to show you, and I really like it because it gets at that message earlier about it's not just long-term care where we're doing interesting things with UTI diagnosis and using medications. This was across all hospitalized older adults. They were defined as over 75. They basically reviewed the charts of 260 people hospitalized that got a primary or secondary diagnosis of UTI. Now, the study authors categorized, they had criteria by which they categorized UTIs. Symptomatic meant localizing signs and symptoms, dysuria, frequency, urgency, documented, localizing. Bacteremic UTI, positive blood culture with a clear uropathogen. Presumed UTI, I like this one, because it actually addresses that issue of cognitive impairment. So for people with cognitive impairment, documented cognitive impairment, or an indwelling urinary device, if they had signs or symptoms of sepsis, even if that was the only thing, they would put them into that presumed UTI category. And then the non-UTI, negative urine culture or no criteria being met. And just to clarify, the signs of sepsis were an elevated temperature, pretty low baseline. I mean, the threshold was low to call it a temperature, greater than 37 degrees. That's greater than 98.6. A white count greater than 11,000, or a C-reactive protein that was greater than 10. Now, this was a study done in England, and they tend to use more biomarkers in Europe than we do in the US. So that's why CRP was incorporated into their signs of sepsis. So in the flow chart, which is impossible for you to see, but I'm going to tell you about it here. They started with 301 individuals that were diagnosed with UTI as a primary or secondary diagnosis, of which 265 were eligible for their chart review, so the vast majority. Of that 265, just shy of 60%, 150, met the authors defined UTI categorization. 64, or about 43% of those people, were symptomatic UTI. 20 were bacteremic, and 66, or 45%, were presumed UTI. They had 40% of the total not UTI at all. Of those, that 43%, there were 12 that had symptoms but a negative culture. The rest of them, a big chunk, actually almost 40%, were asymptomatic bacteriuria. And then there was the 60% that I didn't show you, had no positive culture, no signs at all. Okay, so that's how the non-UTI group fell out. The majority of them were completely negative. 40% were considered asymptomatic bacteriuria. 10% might have been symptoms, but a negative. There was no culture to confirm it. So now let's see. This is comparing then the 150 that fell into one of those three UTI categories compared to the 115 that were non-UTIs. And the group, the lines in the box are highlighting dementia, chronic urinary catheter use, and having a catheter at the time of diagnosis. Those were higher prevalence in the UTI folks than the non-UTI. Although with dementia, it was 39% in the UTI group versus 25% in the non. So it wasn't widely different, but it was significantly, statistically different. The other thing, history of prior UTI was toward the bottom, overrepresented in the people with the UTI diagnosis, met those criteria. How about the presentations, and these are the urinary tract specific localizing presentations. So any of the list here, we've got dysuria, hematuria, frequency, urgency, retention, suprapubic pain, flank pain, rigors. There was a lot of them were overrepresented among the UTI folks compared to the non. In particular, dysuria, 20% of people with the UTI versus only 3% without. Remember, that's a little different from that other study we looked at where dysuria was about, I think, 40% of people with dysuria in that cross-section had bacteriuria and 60% didn't. But this is, remember, people with clinical suspicion of UTI diagnosed in the hospital. And so we're retrospectively applying criteria. Frequency, 10% among the UTI, or I'm sorry, 15% among the UTIs versus 4% in the non. And any of those, you saw 50% of the people in the UTI category had one or more of those UTI symptoms versus only 10% in the non. How about the geriatric symptoms, the syndromes? That's falls, confusion, incontinence, functional decline. None of them were statistically more prevalent in the UTI group versus the non. I'm going to say that again. None of them were statistically more present in the UTI group than the non. And I think, again, here's another study that is telling us that our paradigm needs to change. Other things they looked at, urine is pungent, urine is discolored, patient smells like urine. None of them statistically more present in the UTI group versus the non. So change in the character of the urine, I feel completely okay throwing it out as a sign or symptom of localized UTI. And this is data that backs it up. Any questions about this? I know I'm going to send you this paper so you can see it in better print. Now, this slide is kind of going through the culture data. So in total of that 265, only 20% had no culture sent at all. Only 30% had no growth. And in the group that had a positive, met the UTI criteria, 21% of them had 21% of them had no growth. Whereas in the non-UTI group, 39%. And that was statistically different, meaning that more people in the non-UTI category had no growth in their urine culture than the people who were in the UTI category. Now, remember, this is the categorization done after the fact, which means all of these people got treated like they had UTIs in the hospital. But what the authors have done is applied their criteria after the fact, and you're seeing these differences falling out. Not surprisingly, the coliform, so the GI bugs, Enterococcus, E. coli, Enterobacteriaceae, the Klebsiellas, those were the most prevalent organism identified in a positive urine culture. And there really wasn't a difference in whether you had symptoms or not. If you had a positive urine culture, most frequently it was one of those. In fact, 80% of the time or more, it was your E. coli's and Klebs and things like that. Blood culture, just to say that 64% of the total population did not have a blood culture sent. And it was different between people with UTI. It was 58% of those didn't have a blood culture sent versus 75% of the people who did not have a UTI. No blood cultures done. Among the group that had blood cultures sent, in total, 20% had no growth, 7.5% had a positive culture for a uropathogen, and about 7% had a contaminant, skin contaminant. The other thing that they did then was look at the type of, among this group that got treated and managed like they had a UTI, they separated them across complicated and uncomplicated, and it gets at your point about duration of therapy, and we know that if it's truly an uncomplicated UTI, you could probably use a shorter duration of therapy. This is how the authors define complicated. Structurally abnormal urinary tract, which is most of our people, indwelling catheter, immunocompromising condition, and they included diabetes and older men because of prostate enlargement and urinary retention obstruction. Yes? So the comment is that nursing home residents, they were writing guidance to talk about complicated, what is a complicated UTI, and they lumped all nursing home residents into the complicated UTI bucket. Do we agree with that? No. I don't agree with lumping all nursing home pneumonias as the multi-drug resistant complicated hospital healthcare pneumonias either. I think we overexpose our residents to very broad spectrum antibiotics by doing that, but that's what the guidance says, yes. So her point is that people in the acute care side are getting messaging to treat nursing home residents with much broader antibiotics for longer duration because they're being lumped into this bucket of they're all complicated. Well, and it's driving a lot of unnecessary antibiotic exposure. It's unfortunate. We need to show them this kind of data so that they can stop doing that. But what I was going to say, actually, is I thought that this definition of complicated was pretty broad myself. But even given that, there was no difference in the number of antibiotics or really the duration of antibiotic dispensed, no matter what. If I had a complicated UTI, I got 7 days. If I didn't, I got 7 days. And if I didn't have a UTI, I got 6 days. So didn't matter. It really doesn't matter, apparently. But this is another issue that we're not thinking about. Why are we using antibiotics for this long? And I gotta just, if I have time, I'm gonna take a quick aside to say, when it comes to duration of therapy, a lot of infectious disease guidance is made up. I mean, back in the day, you had these experts sitting around saying, okay, what's easy to remember? A week, 2 weeks, 4 weeks, okay, that's easy. Multiples of 5, 10, 50, that's easy. I just think we were trying to be, I don't know what we were trying to do, but we certainly didn't have science behind our decisions around treatment decision. And it's interesting, every single time we've looked at duration of antibiotic use, we are cutting back the number of days we need, right? We used to treat all pneumonias for 14 days. We treat them for 5. We treat the vent-associated complex for 8. Okay, so 14 is way out of bounds. But the question I have is how many of our providers out in the communities that aren't necessarily going to the meetings and reading the literature know that? How many of them are just going complicated UTI? It's a dude, 14 days, I'm done. Now, now the other question I have is, what is our goal? What is our goal with these antibiotics? And this is where I think, especially in our nursing home population, we have to be more thoughtful. Because the goal is not to sterilize the urine, is it? Can we? The antibiotics aren't going to undo their stroked out bladder, right? It's not going to undo the prolapsing rectum that's preventing complete void. So the antibiotics aren't going to sterilize the bladder. And if that's recognized, then we can tailor our treatment to what? Symptom resolution? Return to baseline? How many of you have seen somebody who got an antibiotic to which the organism was completely resistant, but oh my God, 2 days later, they're better? Well, okay, what? You know, you didn't need, maybe you didn't need the drug at all. They would have been better in 2 days regardless of what you did. But it certainly says to me, you don't need to change the antibiotic and give them another 10 days. Oops, it was the wrong drug, you know, let's redo it. But that's what we do. And so this is an opportunity. And I think what I loved about this paper is it really pulled out a lot of the, you know, questions that we have about, are there real differences? Maybe those people meeting criteria are somehow different, and certainly they are in certain places. But it also shows that there's a lot of mythology that we should undo, and that's falls cause UTI, or falls are due to UTI, or you know, just general fatigue is due to UTI. Those are messages we have to change. Now, the other thing to note that they mentioned specifically was that there were 20% of people who had chronic indwelling catheters that got them changed before treatment. The other 80% who had chronic indwelling catheters got started on an antibiotic without changing the catheter. Is there a problem with that? Why? They need it. It's not like it's going to, you know, they have to get a new one. Why do I have to change it? Think back. We talked about this years ago. So biofilms maybe is a thing going through your mind, right? There's a slime layer coating that catheter that we know the antibiotics aren't going to penetrate, which means there's a reservoir of protected organism that is getting exposed to subtherapeutic levels of drug for prolonged periods of time. And what does that do? Resistance. It just drives resistance. So one benefit to changing the catheter is to remove that burden of slime, bacterial slime. That's how I think about it. I don't know, it sticks with me that way, no pun intended. And the other is, if you remove it and put a new catheter in and take your urine specimen from the new catheter, you're less likely to be culturing slime and more likely to be culturing the pathogen causing symptoms. And so, or you may find that you don't culture anything at all because it wasn't a bacterial pathogen problem at all. It was obstruction in the functionality of the catheter, and as soon as you changed it, guess what? You relieved their obstruction, the sludge went away, they drained their bladder, fever is gone. I can't tell you the number of times I took care of people in the LTAC where that very thing happened. We just changed the catheter and their fever and everything went away. No antibiotics at all. So those are a lot of reasons. No, that's the thing. They are pulling the specimen right off of that catheter, and that's a problem. Yeah, very good point. So the question was, well, how were they getting the specimen if they weren't changing the catheter? Well, they were just pulling it right from that one. Okay, the last thing they looked at was outcomes. And I'm just going to talk about the bacteremic cases because that's where you saw longer length of stay, higher mortality, more frequent risk of C. difficile developing during the hospital course. And I guess this really struck me because if you remember, a very small proportion of people actually got tested with blood cultures to begin with. But then when we got blood cultures, 1 in 5 of them were positive. with a real pathogen. And it made me wonder if we weren't missing more of these infections because we weren't looking. And largely the messaging has been nursing homes should not be doing blood culturing because there's concerns of contamination, there's concerns about how quickly you get the data back, and so you're doing something and then it's not timely. But maybe for the people who are getting admitted to the hospital, we need to look at our practice around their overall assessment. Interestingly, almost all of these people with bacteremic, they all had at least one of those signs of sepsis. Remember the elevated temp, white count, or CRP? But only 8 of those 20 had a local UTI sign or symptom, which gets at that concern that some of our severe infections present atypically. It actually is true. So, but if they've got systemic inflammation, go look for something. I mean, I think that's my message from that. So in this cohort, we had a diagnosis of UTI. Only 32% of them actually met those localizing signs and symptoms. None of the nonspecific symptoms were actually associated with any of the criteria-based UTI categories. Blood culturing was not done a lot. Bacteremia overall in the cohort was less than 10%, but among those tested, it was actually 1 in 5, 20%. And then that sepsis symptoms presented in all of the bacteremic UTI folks, and 84% of people with symptomatic UTI met one of those 3 sepsis criteria as well. It makes me think that 84% maybe should be getting blood cultures just to make sure we're not missing something going on there. And the last thing they pointed out was of the 32% of the people who fell into that clearly negative, no UTI category, had their negative urine culture available before they started antibiotics, and they still got antibiotics. Okay, so I am running out of time, but I just have a couple of slides on different measures that you could use to look at the process change as you are doing UTI management activities, things like how adequate is the assessment and documentation. I think that's a huge issue. How are we using diagnostics? Avoid testing those nonspecific signs and symptoms. We clearly know that it's not helpful. Make sure that culturing is done before starting antibiotics and things like that. Good practice that we know. Also, when it comes to looking at outcome measurements, adhering to your management algorithms, how are you going to know that? Well, you could look at the proportion of residents who are meeting criteria for UTI among all of the people who are started with antibiotics for UTI. And, ideally, that proportion becomes equal. But if you see this big disconnect, which right now I suspect you would, that is a starting point for a conversation. You can look at days of therapy, or you can look at the number total of antibiotics for UTI if you're trying to reduce the exposure people are experiencing. And then long term, you want to make sure that you're not seeing a rise in your numbers of hospitalization transfers, or you can look at trends in your C. difficile as well. So I think between Dr. Fatigati and myself, we've convinced you the work is just beginning. We appreciate the work that you're starting and have already been doing, but we do continue to struggle with this. And I think acknowledging that challenge is the first step to actually making good change. And also, really, we have an opportunity to educate everyone that we work with about this non-specific symptoms triggering clinical assessments for UTI. I think the data is overwhelming that we need to change that paradigm. And that is not an easy paradigm to change, but it's folks like you knowing data like this that starts the conversation. And in terms of diagnostic testing, I think really, negative results should really rule it out for you. Positive results are less helpful, so we need to be judicious in how we do testing. I do think, or wonder anyway, if we should consider lowering the threshold for testing in blood cultures among those individuals with sepsis-like syndromes, because we may find that there's more bacteremia happening. But what's remarkable, if you think about it, is that yeah, bacteremia is happening, but these people aren't keeling over and dying. It tells you that the blunting of our immune response as we get older is protective in a lot of ways. And yeah, we may be more vulnerable, and there may be more bacterial colonization of our system, but we also don't get as sick initially. We have a little bit of time, thankfully. Sometimes people get very sick, but if you think about one of us with bacteremia, I mean, I'd be on the floor. I would probably be, halfway to coma if I had, bacteria hanging out in my bloodstream right now, because my immune response to that would be so dramatic. Whereas we may be actually having a little time and a little space to manage people who may be getting sepsis-like syndromes, and we're not actually identifying it. And the biggest issue is dealing with the perceptions of our frontline staff, our providers, our family members. It's critical across healthcare to get buy-in as we try to change these algorithms and implement better work. So I'm going to stop there. I'm happy to take questions. And thank you again for this. It's been great. Yes.
In the acute care setting, is there a recommendation for the quantity of fluid that a patient should be getting either IV or orally if they have an indwelling Foley catheter?
That is a great question. And off the top of my head, I don't think that is that there's any specific guidance around hydration in the presence of indwelling urinary catheters. That being said, there should be, because I think a real big piece to good catheter management, especially when they're chronic catheters, is hydration and maintaining good flow. People do this regular changing of catheters, on a schedule once a month or things like that. Some of it, I've been told, is driven by payment and reimbursement, so I can get it reimbursed if I change it once a month. If I try to do it more frequently, I don't get paid for that. But largely, the data doesn't recommend scheduled or routine changing of catheters, but I wonder if part of why people do it is it's actually reducing the likelihood of sludge and kinking and obstruction and loss of the functionality of the catheter. And I don't know that we've actually explored that potential, that the changing something on a regular basis prevents catheters from getting that much sediment and build up to where they're not working as well. I do think that catheter failure is a huge explanation for catheter-related sepsis, because if you're not draining the urinary tract, all of that bacteria that's hanging out there just starts to go refluxing up into the upper tract. Yeah, it's a great suggestion. I should look that up. And if I find something, I'll let you know. Any other questions or comments? Does anybody want to share some of their cluster experience? I know some of you are doing stuff. I've heard.
I just had a question about dipsticks. I have a client that had 290-bed nursing home. They locked them up so that the only time somebody on the unit can use them, they have to go to the nursing supervisor to get them. And what that does is forces a conversation about what's going on with the resident and initiating their nurse-driven protocol to give hydration.
Yeah.
And I was wondering what you thought about that.
I think that's brilliant. Lock them up. I like that. We should be forcing conversations. Thank you for sharing that, because I agree that if we're not being thoughtful, again, on how we use these diagnostic tests, they send us down a path that we may not end up wanting to go, but now we're forced with data and results that we have to respond to. Now, there are ways around that, by the way. I can document that at the time that I assess this resident and have this positive culture, they are not displaying signs and symptoms of urinary tract infection. They are in their baseline normal state of health. I am hydrating them. I am not going to use an antibiotic. I can write that, and I promise you I can defend it. But if I don't, that's when people get into trouble with, oh, you had this result and you didn't respond. Well, you may have actually thought about it, but if you didn't write it down, nobody else knows what you thought and that you were doing something.